we changed our mind about the potential of people who were receiving services with us. Um, Folks that had only been in a role with us as a mental patient. Now, we had, over the years, had a strong belief and had supported consumer-run services. In fact, we'd started a few organizations that are still going today. But what I believed about that was a good start because I believed that there was good work being done there and there was tremendous value there. But what I noticed was that it was kind of over here on the side. It wasn't part of the mainstream of the service system, and oftentimes poorly funded, many times at risk, sometimes without appropriate infrastructure to really grow the service. And so I began to wonder what it would be like if we could come together, if we could bring those consumer-operated programs into the mainstream of our services. And we said that seems like it could have value, and we could learn from that. But frankly, I had no idea, really no idea, what was going to begin to show up as a result of that. People began to step up. When I first thought about it, I thought, well, where in the world would we find people with serious mental illness who could work with us, you know? So we took some risk. We stepped out, and we created a training program. And people began to graduate from the training program and begin to become employed. Now, it's really important. I want to say that we have a large number of peers that have graduated from our training program in 16 states in the U.S., even in Scotland, and over 100 folks in New Zealand and here in England. The important thing is that it does start with training, but training has got to be for real jobs. We're not going to train people if there's no work. So we've slowed down the training right now in many places because there's no jobs. You know, we're laying people off. Where we have opportunities is when we can create a new service, and there, like we're doing in Washington State now, where we're converting the county-run crisis triage unit into our living room approach, which we can talk a little bit about. Half of the staff there will be people in recovery, will be peers. So there, where we have jobs, we're going to do training. Just a bit about the outcomes of the training itself. Now, sometimes people say, well, I want to come to the training because I've heard it's personal enrichment. Well, it is that, you know, but it is training for real work. So the first year we did this, in 2000, 66 people graduated from the training, and we hired them all. Because by this time, the news had gotten out about RAP, the news had gotten out about some of the other recovery education things that we were doing, and so we had work. So 66 people graduated, they were all hired. And our evaluation partner, Bill Anthony, his team at the Center for Psych Rehab at Boston University, did a study of the first cohort of peers that we employed, and administered a series of standardized tests. And first of all, on the vocational outcomes, 89% were still working after a year. Now, that's a phenomenal statistic. I think across our workforce, if we had that kind of a retention rate, it would be fantastic. And this is maintained. This has sustained itself over the years. And you see an increase just from the training in empowerment, in recovery attitudes, and in self-concept, because what's happening here is people are beginning to really get a hold of what recovery means. And part of the training is understanding myself and how to give my gifts of my life experience in a way that can help others recover. So, we changed our mind about the role of people with a serious mental illness. Created a new discipline, in fact, that we called peer support specialist. We didn't know how to label this in the beginning, but that's what we landed on. And we began to create a new workforce. So today, I would say that this has pretty much become a global movement. And in the U.S., at least 20 states recognize peer support as a benefit or a covered service in their Medicaid program. The Center for Medicaid Services that funds the Medicaid program in 2007 endorsed peer support as a best practice and encouraged states to move forward with creating peer support as a service in their mental health system. So what did we start to notice that showed up as we began to bring peers onto our teams? First thing, people's recovery grows by leaps and bounds. And it's not just about having a paycheck, although that's a good thing, you know, to improve people's quality of life. But it's also being valued, making a contribution that's important, giving back to other people. And people began to grow in their recovery. And we saw amazing things happening with people who were receiving peer support grow in their recovery. Now, we haven't done very well in our system at engaging people that say no. Now, we've got our ways, right, of bringing people in. But what we noticed with the peers is that they were much better at being able to engage people in services that previously had not been willing to be engaged with us. Part of that is the kind of natural credibility, the natural credential of life experience that they bring. They've been there. We encourage our peer staff to use the credential ITE behind their name, which is I'm the evidence. It's me. I'm a real person, and yes, I was in your shoes. The concepts of peer support, grounded in mutuality, grounded in relationship, not fixing, but rather being with. It's a powerful thing to be with somebody in a distressing moment in their life. Just not having to do anything except bear witness to their experience. That connection between us is very healing. And the other thing that we did not have intention or knowledge that would show up is that it helped our organization become more of a recovery-based organization. A redefinition of our roles together. Someone that has been exclusively in the role of patient becoming my colleague. Now that didn't happen by flipping a switch. And in some cases it didn't happen easily, but I can tell you that quickly it happened. We know that the beliefs that we often bring may be grounded in biases, past experiences, and sometimes even stigma. The way we overcome that is through getting to know each other. And as we got to know people in a different way, in a more complete way, it redefined what we thought was real, our reality. If you work in a hospital, if you see people in crisis and emergency services, and you're seeing people really when they're at their most difficult times. And what I found with the staff when I started having the discussion about recovery values was we got stuck right away on the first value of hope. They didn't have it. You know, there wasn't much hope anywhere. But when Tommy showed up, who 6 months ago had been a patient in the hospital, and he was looking good, and he had a smile on his face, and he was participating as an equal member of the team, suddenly it changed how I felt, right, about what was possible. And I got a burst of hope, a dose of hope myself.